This conference will now be recorded.
Hello. Hello, everybody. Welcome again.
Okay, Dr. Rasha. Dr. Rasha, can you please repeat one question? Like you are telling that for the laparoscopic ovarian drilling, it should be 4 by 4. What do you mean by that? Can you please repeat that one?
Okay, just I mentioned that for the laparoscopic ovarian drilling, okay, it is prescribed as I thought for if the question came to you, the EMQ, you will choose that the patient will try the clomiphene and failed, and then she had a normal weight, BMI mean, and high LH, hypersecretion of LH, so that you choose laparoscopic ovarian drilling, and that you should know that to decrease to minimize the risk for the laparoscopic ovarian drilling, you will, for the ovary, I mean, because you will counsel the patient about the possibility of oophorectomy, so that you will tell her, you will tell her about the oophorectomy to counsel her before the laparoscopic ovarian drilling, and that to decrease the risk of this, you will minimize the discernment point to 4 points per ovary, means that this is the ovary, you will discern just 4 points, okay? For a 4 second means that just 4 seconds at like this, just a touch, like at 40 volts, okay? Actually, the action of this laparoscopic ovarian drilling is exactly not known, but they said that the thermal damage restores the ovulatory cycle by normalization of the pituitary LH. Okay, let's start to solve the question. So, yeah, exactly. So the first question we solved it before, a woman with tubal disease. Just I will repeat it because this is the record started. A woman with tubal disease advised to have IVF treatment to maximize her chance of ovarian, so that the percentage of the patient with severe, the chance of developing severe ovarian hyperstimulation syndrome requiring hospitalization in women undergoing control ovarian hyperstimulation is, the answer is B, which is 1 to 3%. Okay, and we tell about the is that it is talk article 2012 is that among women undergoing control ovarian hyperstimulation for IVF, 15 to 20% may develop mild to moderate ovarian hyperstimulation, and with the severe type that who require hospitalization is about 1 to 3%. Let's go for the second question, please. Who will be for the second question? Who will the volunteer? Hello.
What is the predominant cause
Yes.
of infertility?
Yes.
PCO.
Yeah.
Answer is B.
Yeah, excellent. It is PCO. Yeah, this is an easy question. This is a gift, actually. You are very lucky. Okay, the third one. What is the first line pharmacological treatment for anovulatory polycystic ovary syndrome?
Yes, it is clomiphene.
Yeah, it is clomiphene citrate, as per NICE guideline. It is still used as the first line treatment for anovulatory PCO. Okay. Question number 4. A 32 years old who want to volunteer to solve this question and to be, and who will want to answer it as well? Hello.
Can I try?
Yeah. Welcome.
It's 2 years. Okay. A 32-year-old woman present to the gynecology clinic with galactorrhea and secondary amenorrhea. Serum prolactin level is measured and found to be elevated. What is the main mechanism by which hyperprolactinemia causes secondary amenorrhea? I think by inhibition of LH pulsatility.
Yes, answer is D.
Answer is D. Yeah, you are right. Excellent. Yeah, exactly. So, high level of prolactin can result in an ovulation secondary to inhibition of the LH pulsatility. You are right. Excellent. This is important question actually. Okay. Following IVF treatment cycle, where 15 oocytes were collected. Okay. A patient presents to the clinic with abdominal pain, nausea, and vomiting. And ultrasound perform and show that the ovaries to be enlarged with mean diameter of 10 centimeter, and there is a small amount of ascites. So who
Answer is
will be
D.
volunteer for this question? What answer?
It is C, moderate OHSS.
It is
Who
B,
answered the
mild
question first?
OHSS.
Just I want the answer first. Who answered the first, please? I just want answer. Who answered?
It's me.
First?
It's me, Kanchan.
Kanchan. What you tell me, Kanchan?
It is moderate OHSS because the size is more than 8 centimeter and ultrasound shows ascites.
Yeah, because I hear that one tell A or B something. Yeah, it is C.
It is
Exactly.
C.
Yeah, exactly. It is C because you have ovary more than 8 and you have the enlarged ovary to be large and diameter of 10, and there is nausea, vomiting, and small amount of ascites as well. So all these by ascites by scan means that it will be moderate ovarian hyperstimulation syndrome. Okay, excellent. What proportion of women with PCO are overweight or obese? This is a very important question and always coming in the exam. Who are the volunteer for this question?
40 to 50%.
How much?
40 to 50%.
40 to 50%. Yeah, all right. Yeah, actually, this is a scientific impact paper. Okay, the consensus of definition of PCO recognize that obesity an association and not as a diagnostic criteria, as only 40 to 50% of women with PCO are overweight. So the answer is B. The seventh answer, the seventh one, who is he want to answer it? Or we can choose one to choose three questions, okay? To solve three questions and then everyone three questions, okay? Who is the volunteer?
Okay. I can.
Okay. Let's start.
It's question number 7.
Yeah.
What type of electrolyte disturbance is often seen in association with severe OHSS? So hyponatremia.
Hyponatremia. Yeah, exactly. Yeah, you are right. Excellent. Actually, it is observed in how much of severe ovarian hyperstimulation? Do you know? In severe ovarian hyperstimulation, how much is it account for severe ovarian hyperstimulation?
Less than 135.
Actually, it is in 56% in case of severe ovarian hyperstimulation. Yeah, and it may be delusional as a result of the antidiuretic hormone hypersecretion, as we know. Okay.
Okay.
The next one.
The next one is number 8. A woman
so
with...
Before we go to the next one, just I want to revise with you. What other kind of the electrolyte disturbance? Anyone? Or you can answer it. Yeah. Apart from hyponatremia, what else?
There is hyperkalemia. Hypoosmolality is also there.
Yes.
And
regarding the hematocrit?
Hematocrit will be more than 0.45.
Yes, high hematocrit, yeah. Okay.
Excuse me, Dr. Rasha. And
yes.
One of the choices was hyperkalemia. And why can't we choose B and instead of E?
D instead of E, you mean? Why E or what? I didn't
B,
understand.
the hyperkalemia, because we said
yeah, but the critical one is the hyponatremia.
Okay.
The critical one is the hyponatremia. Yeah.
Okay, thank you.
Yeah. Welcome.
Dr. Rasha, what is the percentage you mentioned regarding hyponatremia?
It will be critical as hyponatremia, not like hyperkalemia.
No. What is the percentage of hyponatremia seen in OHS?
Hyponatremia, it is about 56%. Yeah, 56%.
Okay. Okay, doctor. Thank you.
Okay, you're welcome. So let's go for the next. Yeah, with you. Who is me? Was? Sorry, I forgot you. Sweetie. Okay, Sweetie. So the next question.
Women with severe cases of OHSS initially presented with 10 ascites, oliguria, and hematocrit of 46%. She was treated with appropriate fluid replacement and hematocrit is now normal range. However, she remains markedly oligouric. What is the appropriate management?
Yes.
It's E, parasynthesis.
Yeah, you are right. Yeah, exactly, paracentesis. Because it should be considered in women who are distressed due to abdominal distension, because this patient actually she's distressed with tense ascites, okay, and still remain oliguuric after management, okay. So this actually in women whom oliguria persists despite adequate volume replacement, and she's distressed with this tense ascites, you will go direct for paracentesis, okay. What is the recommend? The Sweetie, the next one.
The next one is, what is the recommended test for the biochemical detection of hyperandrogenism?
Yes.
It's A.
Hyperandrogenism.
It is B.
It's E.
B.
Total testosterone.
B.
Free androgen.
The free androgen index.
Yeah. Yeah. It is. Why you said A?
Actually, I thought how to differentiate, so I go for A.
Yeah.
But no,
Okay. So the biochemical detection of hyperandrogenism is by free androgen index. Okay, and it is used actually in the diagnosis of PCO. And there is a recommended baseline biochemical test for hyperandrogenism is the free androgen index. Okay.
Yes.
Free androgen index. Yeah, which is the total amount. You know what is the free androgen index? Can you tell me what is the free androgen index? The equation.
Total testosterone divided by SHBG multiplied by 100.
Yeah, you are right. Yeah, thank you. Okay, another volunteer.
Dr. Rasha, this is Dr. Uzma speaking. In PCOD case, after diagnosis, after ultrasound diagnosis, is this the test we do, the first test, biochemical test, free androgen index?
The first test you mean, or what?
No. After we, suspect polycystic ovary and we diagnose it, they ask us what is the first. What's the next biochemical test you do it?
Yes, this is the one.
Yeah, this is free
Pre-androgen
androgen
index.
index. Yeah.
That.
Yeah, this is the one. Yeah, exactly. Because it's written even in the guideline, in the GTG. Okay.
Okay. Thank you.
Okay. I think this is the repetition. Overweight, obese. Okay. So, who will volunteer for the next question? The second coming 3 question.
Can I do it?
Yeah, you are very welcome.
Yeah, what is the mechanism of action of metformin? It enhances the insulin sensitivity at the cellular level, increases renal glucose reabsorption, inhibits insulin release, promotes hepatic glycogenolysis, and promotes hepatic gluconeogenesis. I think I would go with A. It enhances the insulin sensitivity at the cellular level.
Exactly.
Yes, answer is A.
Yeah, answer is A.
Yeah.
I mentioned, I think, in my lecture today, it will enhance the insulin sensitivity at the cellular level. Okay?
Yeah.
Excellent. Yeah. So the next question.
Next question, what is the estimated prevalence of endometriosis in infertile? Is it 10, 20, 30, 40, and 50%?
The answer is?
It's 30.
50%?
It's 50%.
50%.
50%. Sorry, it's 50%.
Yeah, it is 50%. Okay.
Yeah. And the next one is, what endometrial thickness should have been achieved in order for embryo transfer to proceed? I think it's minimum
Should
5.
be more than 5 mm.
5 actually. Yeah.
So before we will solve this question regarding the endometriosis, what is the prevalence of it in a woman of reproductive age? Because this is a common question, even also you will see it in the exam.
20%. It's 10 to 20%.
2 to 10.
2 to 10%. Yeah, you are right. 2 to 10%, the prevalence of it in reproductive. Okay.
The 11th one is 5, more than 5, isn't it?
What is it? More than 5. Yeah, it is 2 to 10%.
More than 5. Yeah. It is more than 5 for a embryo transfer to occur. Yeah, in order to do the embryo transfer.
Which question you answer? I didn't understand you. Which one?
No, that was the 11th one.
11. Yeah. What is the thickness? The endometrial thickness? Yes.
E.
It is E. Yeah. It is E. Yeah. It is according to NICE guideline, replacement of the embryo to the uterine cavity with the endometrium of less than 5, unlikely to result in a pregnancy. Okay, so it is not recommended.
Doctor, what is the percentage of 2 to 10% you just mentioned?
This is for the prevalence of the endometriosis in reproductive age woman. Okay.
Prevalence of endometriosis in?
The prevalence of endometriosis in reproductive age woman.
Reproductive age.
Yeah. Okay. The next.
How much prevalence in an infertile couple?
We mentioned
50%.
it in the question. 50%.
50%.
50%.
Yeah.
Okay.
This is another question. I am asking about another question. The question in the question here is about the infertile woman, but I'm asking about the prevalence of endometriosis in a normal reproductive age woman. Okay.
Thank you.
Yeah. Let's go next.
Yeah. Do I have to continue or someone else will take over?
You complete 3? Yeah. Volunteer. Okay.
Yeah, I did.
Yeah. So volunteer for the next 3.
Yes, Dr. Rasha, can I share?
Yeah, of course.
Number 12, subfertile woman presented with severe cyclic pelvic pain, ultrasound show 4 cm right ovarian endometrioma. The most appropriate treatment is laparoscopic cystectomy. It is B.
Yeah, yes, exactly. According per the ISHRA, the new one, it recommends this. Yeah, excellent. Okay. So
The next one.
the next, yeah.
Male factor infertility, most appropriate test. Can you move the screen?
Just 1 minute, just 1 minute. Yes.
Healthy man with no problem in erection or ejaculation, no complaint apart from infertility urgency. Palpation show bilateral absence of the vas difference and semen analysis confirmed as spermia. This obstructive, not obstructive, this is testicular cause, I think. In testicular, what we will do?
This is, there is a clue in the
Answer is
question.
B.
No, she's answering now. Just let her to answer. Give her a chance, please.
Okay.
So
this cystic fibrosis, we will do test for cystic fibrosis.
we will test for cystic fibrosis. Why? Because she had a bilateral absence of the vas difference. Means that this is a clue for the testing for cystic fibrosis. Okay.
Okay. Next one, healthy, no problem in erection or ejaculation.
But I think the
show...
question here, just 1 minute. I think the question here have I think wrong information, because he write that semen analysis confirm as azoospermia. The cystic fibrosis, you will have bilateral absence of the vas difference.
Normal. Normal semen.
I think normal.
Must be normal.
Semen analysis. Yeah, must be normal.
Yes,
so that this is a wrong idea in this question. Okay, just so if you read the question, see it carefully.
So if it is absent vas, then it will be like same like obstructive azoospermia. Semen.
Yeah, semen is normal, but there is bilateral absence of vas difference. Okay, because the Klinefelter, it's responsible for 2/3 of the azoospermia. Okay.
Dr. So the answer is in cystic also there will be azoospermia.
Yeah, but not so much. Sometimes you will found normal semen.
Like oligospermia.
In which cases we
because bilateral
male karyotyping for abnormal semen analysis, what will be done with male karyotyping?
I didn't hear because there is.
Hello, Rasha. Don't getting.
No, I didn't hear because there is.
Not getting anything.
I asked the question, what will be the threshold of semen analysis doing male karyotyping? Because in some answers we get answer is doing male karyotyping if gross semen analysis is abnormality shown.
I remember this question actually before because we go with it, but I think it was serum testing for cystic fibrosis.
Okay.
Yeah, because we solved it before. I remember it in our group, secrets group. This question, at the end, we found that it is a serum.
So Dr. Rasha, excuse me, for how is going to be a bilateral absence of the vas and to have a normal semen?
Because this is the criteria as before. We see that this one, the cystic fibrosis, you will have bilateral absence of vas difference, but if there is semen analysis, you found it normal.
So what would be the answer for 13?
13
no, because
will be
vas are absent, so there will be azoospermia.
I think there is no azoospermia.
How the sperm will reach without the vas?
It will be azoospermia with absence was azoospermia.
But some of them, I think they have normal semen analysis. Not all.
Then they will have so they will not have a bilateral absence of the vase.
Yeah,
Some of them
bilateral
have
absence means
unilateral and
complete.
some have bilateral.
Yeah, it's okay.
Not all have bilateral absence of the vase, friends, actually. First, you will do serum testing, and then you will confirm by karyotyping. Okay. Okay.
So here for 13, now what would be the answer?
B, serum testing.
Serum testing for cystic fibrosis.
Yeah, to screen first, then to confirm by karyotype. Okay.
Okay, I will continue.
Yes.
Healthy, no problem in erection or ejaculation. Semen analysis show count of 6 million per mil. I will repeat the semen analysis after 3 months.
No.
Immediately.
It is more than
Repeat
5,
semen
not
analysis
immediately.
immediately.
No, immediately if severe, like less than 5 million.
Yes.
What I think.
If it's critically severe, yeah, exactly. If less than 5, you will go direct for repeat it as soon as possible. But this now, it is not severe oligospermia, so that you will see, which is repeated semen analysis after 3 months. Yeah, you are right.
Yes, you mentioned that, Dr. Rasha.
Yeah. Question 15.
The complete 3. Next one can share.
Hypothyroidism. Previously healthy. Yeah, you can say. You complete your 3 question?
Yes, I complete. I will chance for another.
Okay, who will volunteer for other? Who is the volunteer?
Dr. Rasha, if semen analysis semen count is given less than 1.5 or 0.5 million, then we do karyotyping or as soon as possible.
Hello? Hello? We first screen for cystic fibrosis. First things. Okay? If you screen that this is positive for cystic, we do karyotyping for confirmation. Because sometimes you can find cases that with bilateral absence and maybe even not cystic fibrosis. Okay, and even sometimes by karyotyping you cannot find cystic fibrosis even by karyotyping. So you will not do it unless you screen positive, and then at that time you can do cystic fibrosis confirmation by karyotyping. Okay, who is volunteer for the next question? 15.
Okay, me. Previously healthy and has fathered a child before, but now complains of excessive fatigue, and he failed to produce semen for testing twice. Can you go up, Doctora? Can I see the option?
Yes.
Measure prolactin level.
Fatigue and failed to produce him for testing twice. Yeah, it can be here. This question actually there is. Hello.
Yes,
Hello?
measure prolactin level.
Yes, measure prolactin level, and if there is another answer, it can be also thyroid.
Yes.
Okay, another option for this question. You are right. Okay, 16. I think if prolactin less than 1,000, it's thyroid. We can consider thyroid, but if more than 1,000, then MRI. Which question you mean? The 15 you mean? The same question. Same question. If prolactin, yeah, less than 1,000 or more than 1,000. Yes, exactly. Yeah, you are right. But here this question actually asking about regarding regarding either thyroid or prolactin. Okay. The other one, 16. A healthy man previously fertile, but he noticed some urgency, dysuria, turbid cloud urine after sexual intercourse. I think this is retrograde ejaculation.
Notice emergency dysuria and turbid cloud urine after sexual intercourse. Just not obviously
urine for microscopy and
refer to urologist. For 16, it would be refer to urologist.
For which 15 or 16?
16 for 16.
Why?
This
is retrograde ejaculation.
Yeah.
You mean the last one?
Yeah, last one, 16.
The last one is urine for microscopy and culture. If you found any problem, you will send her
urine
for
microscopy and culture. Yes.
Yeah, you will send her for the urology. Okay. Yes. Yeah. So the next question.
Dr. Rasha, the last question, 16. It is urine for microscopy and culture for urinary tract.
Yeah. Exactly. Actually, this question, when we answer this question, if you saw the paper which is sent, I think the recall, this is sent by me before. Actually, I remember this question because I found this answer for this question. It is microscopy, urine for microscopy, and culture, and if it is positive or there is infection or things like that, you can give antibiotic. But if it's still the problem, you can send her for urology. You can send this one is for urology immediately. Okay.
Okay, then first we have to do urine for microscopy and culture.
Yeah, first things. Yeah.
Okay.
Because the GB first will do this. The GB. Okay. The first thing he will do this.
Yes.
Then after that will be sent for the specialty. Okay.
Okay. Thanks.
Okay. What is the most common cause of subfertility in UK? It's male factor, 30%. So please, can you mute yourself, others? Because, yeah, please.
رشا بليز السؤال اللي قبله 15
either major prolactin level, or if there is another option for example, thyroid, you can choose it. Thyroid test, okay? Another volunteer. What is the most common cause of subfertility in UK? It's male factor, 30%. Yeah, exactly. Yeah, exactly.
Not unexplained.
Okay, I finished my. You finish? Okay. Who want to? Hello.
Can I?
Dr. Rasha, can I?
Yes, you can. Yeah, you can.
Okay. 36 years old woman is being investigated for primary infertility. She has no significant medical or surgical history. Her partner is 39 years old, non-smoker, with normal semen analysis. Her hormonal profile, FSH score, LH is 2, TSH is 1.7 on day 2, and serum on day 21 was 40 nanogram per deciliter. I think I will her investigation with the normal. She's ovulating
Mhm.
and with normal FSH and LH. I think we will check her tubes.
So what we will do? Which investigation? You are right.
Laparoscopy and dye test or hysterosalpingogram. Always I'm confusing between choosing which one.
No, but because today I tell when you will choose this hysterosalpingogram and when to choose lavandai. You remember what I mentioned?
Really, I'm asked the question also, but you didn't reply for me. I don't.
Okay, so no problem. We'll tell it now. Actually, this patient, she's 36 years old, being investigation for primary infertility. Okay, no significant medical or surgical history. Okay, so this means that she didn't have any history of ectopic pregnancy, history of PID, any history of, for example, previous ectopic or PID, or endometriosis. Okay, 3 things. And so all these criteria met. So you will go direct for hysterosalpingogram.
Okay.
So the answer is hysterosalpingogram because all these things are not there. But if all these there, you will go for your answer, which is lavandai.
Okay.
Okay. The next one, yeah, just.
A 36 years old woman is being investigated for infertility for 3 years duration. She has a history of right salpingectomy done 4 years ago. Her husband is 41 years old, non-smoker, and with normal semen analysis. Her hormonal profile is normal. This one I will choose lavandai.
Yeah, exactly. Excellent.
Yeah, good.
Alhamdulillah.
Alhamdulillah. Speaks for me, alhamdulillah.
Alhamdulillah. Yeah. Question 20.
The fertility workup of women showed high AMH. What can we predict from high level of AMH? Having
Yes.
high risk of IVF success.
Yeah, exactly. Yeah, its answer is D, which is higher chance of IVF success. Okay.
Sorry, Doctor, also high risk for
Not high risk for
ovarian
OHSS.
hyperstimulation.
Yeah, high risk for this and also high risk for the answer, high risk of ovarian hyperstimulation syndrome as per talk. Okay, I put both of them. I want to tell you is that if came to you the question without higher, for example, we omit higher risk of ovarian hyperstimulation, it will be higher chance of IVF success. If they will omit for you higher chance of IVF success, it will be higher risk of ovarian hyperstimulation syndrome. Okay, but just I put, you see, I put both of them. Both of them, you can choose it. Okay, but the critical one is the higher risk of ovarian hyperstimulation syndrome. This is the critical, as per the talk, the new talk. Okay.
So if the both come, I choose one. Choose which
If
one?
both of them, if both come to you, you will choose higher risk of ovarian hyperstimulation syndrome. As per the talk guideline.
Dr. Rasha, please,
Okay.
there is a question in the recalls that he put
Yeah,
them
I know
both
it.
in the same
I know it.
stem, higher chance and higher chance of OHS, both of them in the same option. Then the next option is lower IVF outcome and high risk of OHSS. What to choose? The cutoff was 25. He mentioned that AMH was 25.
Always you will choose higher risk of ovarian hyperstimulation. This is
Both
put in your
of
mind.
them
Always you
were
choose it.
in the same option.
Higher risk of ovarian hyperstimulation and the other one, and what with it?
No, you didn't got my point. He mentioned one of the options, higher chance of IVF success and higher risk of OHSS. The next one was lower chance of IVF outcome and higher risk of and higher risk
So
of
we will go for
OHSS. What do
higher
you think?
risk of, you will go for higher risk of ovarian hyperstimulation and higher chance of IVF success. The
Okay,
same.
okay.
Yeah,
Because
both of them.
in the
That's why I
recall it
mentioned
was
it.
solved
Yeah.
as lower chance of outcome.
No. I am.
Okay.
We thought before, if it is the antral follicle and the AMH, if it is high, it will means high response. Okay.
Okay, doctor.
If it is
If
low,
it is,
low
if the
response.
case was PCO, you know that an AMH it predict poor in PCO case.
This will go for
What do you
ovarian
think?
hyperstimulation. It will go with ovarian hyperstimulation, high risk of ovarian hyperstimulation, more than
And the
success of
outcome in
IVF.
PCO with a high AMH.
It will go
in
with
PCO
higher
patients.
risk of. Yeah, I understand you. It will be go with higher risk of ovarian hyperstimulation and maybe lower risk of IVF success.
Yes,
because of this,
that's what I
because
mean.
of this
Yes.
ovarian hyperstimulation syndrome. If
Okay,
they mentioned
thank you,
to you
Dr.
PCO, okay?
Yes. Okay.
But I remember this question they didn't mention for you PCO. That's why I'm answering.
Yes.
Okay.
Yes. Okay. Thank you.
Thank you so much. Who is the volunteer for the next question? Yes,
Hello.
we have 10 minutes because I spent a lot of time today. This is actually, it is 90 questions. So now just we solve about 20. We will just 10 minutes and then we will complete the rest, the next session. Okay? So who will go?
Okay. Dr. Rasha, I'll do it.
Okay. You are welcome.
Yeah. Which one is eligible for 2 embryo transfer in the first IVF cycle? It is 40 to 42 years. The answer?
Exactly. Yeah, exactly. Okay. The second one,
then
the EMQ.
40-year-old Caucasian couple have.
You should answer this question because today I
Please,
tell
Dr.
about it.
Rasha, you can repeat this last question before this one. This transfer to embryo.
Yeah, this is clear in the IVF in the NICE guideline. You will
40?
Yeah.
Okay.
It is D 40 to 42 for 2 embryo transfer. Yeah. For the first IVF cycle.
Okay, thank you.
Okay. You're welcome.
Yeah.
Okay, the next.
A 40-year-old Caucasian couple have attended the infertility clinic. A lab investigation done by the GP suggests microscopically negative urine analysis of the partner and an ejaculate volume of 0.8 ml with no spermatozoa detected. Seminal fructose was absent. A serum FSH was 8.8, normal range being 1 to 14. So I think it is azoospermia, maybe some donor testicular biopsy. ICSI.
What you will do?
Because there is azoospermia.
40 Caucasian couple.
But ICSI also it should be with the donor sperm, right, doctor? I don't know.
Okay, so now it is mentioned is that he's 40 years old, Caucasian, 40 years old Caucasian couple, attend the infertility clinic. A lab investigation done by the GP and show microscopically negative urine analysis of the partner, ejaculate volume of 0.8 with no spermatozoa. Okay, so all this means that like azoospermia. Okay, severe azoospermia, and seminal fructose was absent. A serum FSH is 8.8. The normal is 1 to 14. 1 to 14. Okay, so this absence of fructose in seminal analysis indicate what? Anyone tell me?
Maybe cystic fibrosis. We will go for the karyotype.
Obstructive azoospermia, I think. Answer is B.
Yeah, for me also B.
Yeah, exactly. Exactly, you're right. It is B. It is transrectal ultrasound. Okay, means that absence of fructose means that in the semen analysis means that there is obstructive azoospermia, and the most common cause of it is that, as we know, it is vasectomy. The most common cause of the obstructive azoospermia is vasectomy. A congenital absence of the vas difference is a cause, okay, associated with it. But to confirm this, we can do transrectal ultrasound. But if he mentioned to you to examine, because here maybe you will not need to go for transrectal ultrasound, because actually if you want to examine this guy, you will easily, if there is no vas difference, easily it will be detected. Okay, so if it comes to you in the question that to examination of the vas difference, first means examination, then after that to investigate, because he not written that to examine for the presence of the vas difference. Are you with me?
Yeah, I'm with you, but I was thinking.
Because by examination, it is very easily to detect bilateral absence of the, okay. So once it is diagnosed, so that you will go for genetic testing for cystic fibrosis.
So first I will choose is transrectal ultrasound.
Yeah, transrectal ultrasound. You are right.
So
but
we
what
do
if they are coming for
ultrasound to visualize the vas difference, if it's there or not?
Yeah, by transrectal ultrasound, yes.
Okay.
Dr. Rasha, they are actually coming for the infertility, so we'll try to investigate, and because they are already 40-year-old, and then even then still we'll take the time to do the transrectal and then further karyotype, then we will refer them to ICSI or something. Is it like that? Yeah.
No, first you will decide. First, you will see if there is. It is like a diagram. First, you will see here there is absence of the fructose. Okay, so it means that this is obstructive azoospermia. The most common of it is that vasectomy, but it can also associate it with bilateral absence of vas difference. So that if he mentioned to you, you will examine the testis, you will choose it. If not, you will go for transrectal ultrasound. Okay, to rule out if there is bilateral, if there is congenital absence of vas difference or not. If it is there, this means that it is most likely cystic fibrosis. So that at that time we will go for genetic testing to rule out cystic fibrosis.
Okay, fine.
Okay.
Yeah, got it. Right.
Yeah.
So the next question: 31-year-old man is seen in the 31-year-old man is seen in the clinic. He has a normal phenotype features with an unremarkable medical history. He has tall stature, height 193, weight 74. Endocrine testing demonstrated an increase in FSH and LH 26.5, 16.9 respectively, and very low level of testosterone. Semen analysis revealed azoospermia. Here it is karyotype because it is called Klinefelter syndrome. Tall and high FSH, LH, and azoospermia.
Klinefelter. Yeah, exactly. Yeah, as I mentioned before, you were with me. Okay, that's good. So it will be karyotyping. Yeah, karyotyping because it is high FSH and LH, and he's tall, and all these things go with Klinefelter syndrome. Okay. The last question.
So I'll continue. Yeah. 28-year-old man has been referred to the hospital with the chief complaint of infertility. He had normal puberty. Serum level of testosterone, LH, FSH are low. Semen analysis has revealed azoospermia. So it is hypothalamic level, but then azoospermia is there.
Yeah. So what you will do?
What is the question actually? The treatment or?
That it is a treatment. Yeah. Choose the appropriate answer. Treatment.
So the options are down or up? I don't know this one.
Yeah, it is actually 28-year-old man referred to the hospital, complaint of infertility, had a normal puberty. Okay, normal puberty. Serum level of testosterone, LH, and FSH are low. So this goes with hypogonadotrophic hypogonadism. Am I right?
Yeah.
So semen analysis has revealed azoospermia.
Azoospermia.
Yeah. So you will go for, before we mention the medication for the hypogonadotrophic hypogonadism, I said I said it today. You remember?
Yeah. Gonadotropin.
I said that we will give HCG
Yes.
or human menopausal gonadotropin, or we will give FSH and human menopausal gonadotropin, or we will give GnRH.
Yes, pulse adult GnRH. You said it.
So stimulation with HCG.
Yeah, exactly.
So answer would be stimulation with HCG.
With HCG, yeah, exactly. This is my today, because I put it for you to know this, because it can come to you in the exam.
Today at
This
least
is the
I got
management
some idea
of
about male infertility. Thank you, Dr. Rasha,
yeah.
really.
Thank you so much, and sorry for the inconvenience, because actually this is for me first time to for the GoTo meeting to arrange this, and I hope it will help all of you. And just if you have any question, just write it in the chat, okay, so that we can answer. And after tomorrow, inshallah, we will complete. It will be a nice session, because it will be.
I didn't attend this question answer session. Only last 3 question I attended. So you will put in the group Telegram there. This one question answers.
Yeah, I will put it. Yeah, I will put it. Of course, I will send it, and also the record. I will send the record. Okay, don't worry. Just the next time, just read the IVF, the long protocol and down regulation and all these things. I will try to explain it. Okay, and we will complete this, inshallah. So maybe the next session will be a little bit long. Okay.
Assalamu alaikum, Dr. Rasha.
Thank you.
I have one request. Can you please add me in your group? I didn't find your group in Telegram. I'm not in your group. Please kindly add me.
Okay, no problem. Just send me to in the private. Okay.
Thank you so
I
much.
have to know you.
Dr. Rasha,
Okay.
please also add me. Dr. Rasha, I'm Dr. Medhat. Please kindly add me.
Yeah, but just send it to me in the Telegram, because I don't know. Yeah, I mean, in the Telegram, I don't know whom are you, because a lot of people send to me. So just tell me, okay? For me, no problem. I will add,
you.
okay, for the benefit of all. Okay.
Okay, thank you.
Okay, thank you. Bye.
Thank you.
Thank you. Thank you.
Dr. Rasha.